Good morning.
Morning.
Hi.
Good morning. How are you?
Good, good. Except the rain.
Yes, it is raining a lot.
Weekend was beautiful.
Yes,
We
actually,
have snow.
I nearly
yes.
forgot that's a winter. We're officially in the winter now.
Yeah, yeah. Okay, looks like we've got a few people joining us this week.
Oh, let me just turn down audio.
Great.
You just let me know when you want me to start there, Jerry and
Sure.
Nancy. How are we doing with people in there, Lindsay, Lucci?
Still have some people joining, so we might want to just give it a minute or two.
Sounds great.
Morning, Eldon.
Morning, Jerry. How are you?
Good morning. Welcome. Welcome to everyone. Mark, Leanne.
I think we might want to get started.
Yep.
Okay. All right, we'll get started. First off, thanks everybody for joining us again today for the Ontario Degenerative Cervical Myelopathy Summit. My name's Jamie Milligan. I'm a family physician in Kitchener-Waterloo, and I am a co-chair, I guess, along with Dr. Michael Failings out of Toronto. First of all, just a really special thanks to everybody, again, who's organized this. So sponsorship from the Ontario Neurotrauma Foundation, our team and Michael's team who've been instrumental in creating all this. It's a lot of work. Our steering committee and Jerry, who will be our facilitator today. So you'll hear a bit more from him later on. I'm just going to kind of go through some housekeeping things, and then we're going to get down to things because we do have a lot to cover today and try to get things into the 2 hours that we have allotted. So the first thing would be is we did have the day last week. I know there's a few people on today that weren't able to attend last week, but thanks for them coming today. We're not going to go through full introductions as we did last week because it would probably just take too much time, and people will sort of meet each other in the small breakout rooms anyway. So as far as some housekeeping things, if you have any troubles, Lindsay Bowerman has sent out an email before about how to contact her. The chat function is there for people to use if they want to ask questions. We have collated those before from the last session. Also, we'd ask that people please mute themselves if you're not speaking, just to prevent background noise. And that is, we are recording this during the group discussion part of things. So just so people are aware of that, if you have any concerns with that, let us know. And we will be trying to take a bit of a group picture as well. And Jerry will let you know about that. Okay, so maybe Jerry, if you want to go on to the next slide. So we did just want to start off by quickly going through a few questions that came up in chat last week and then after the presentation. So just for those who weren't there, shoot, that's bad Zoom etiquette right there. Just for those who weren't there last week, we had a number of presentations to sort of set the stage for today. And today is really about trying to establish what could we do in Ontario on the 4 priorities that were determined from day one. What would be doable things in 1 year and in the next couple of years, 2 to 3 years upcoming. So that'll be our task for today. Jerry will go through it a bit more, but we did have some questions from last week. So what were the diagnostic tools? And we summarize these. What are the diagnostic tools used to establish DCM? In Ontario, how effective, accurate is imaging? So we just jotted down a few notes here, and we would refer you also to the pre-reading that we'd given, but there are some tools such as a modified Japanese orthopedic assessment neuric grading scale, which are DCM specific, but we did explain last week do have some limitations. There's a clinical exam that should be done, of course, and MRI is gold standard. And sometimes it can be supplemented by things such as electrophysiological studies. And there are some other things, but those would probably be the main things. Other tools that are used for neck conditions like the Neck Disability Index have been used, but may not be specific to it. And as we had discussed in last group setting, there really is a need for a diagnostic tool sort of at all levels. And Michael, you feel free to add anything to that if you like as well.
Yeah, so there's, and I think this can come up in the breakout sessions. So a couple of things that have, kind of come out of other processes, including the RECODE process that's informed this, is that we need better assessment tools to kind of to look at mild myelopathy. So there's a kind of a recognition for that. And pain is a major issue for a lot of people with DCM. So we may want to kind of think about, where we might wish to go with better assessments for the neck and arm pain.
Thanks, Michael. Next one, Jerry. And then there was a question about the use of upright MRI. Maybe I'll let you speak a bit more to that as well, Michael. I don't think it's probably readily available around here, but.
Yeah, so I'm, as far as I'm aware, there is no upright MRI unit in Ontario. The provincial government sponsored a think tank and an evidence-based review of this a few years ago, and there was really kind of a lack of evidence. It doesn't mean there isn't a value for it, but there just isn't really evidence around this, and so we haven't been using this. The issue sometimes arises when people might have differences between the extent of compression between a supine MRI and an upright MRI. So if there might be dynamic instability, and so some clinicians will occasionally obtain what's referred to as a flexion extension MRI, but that's something that could perhaps also come up in the in the discussions. And then there is an emerging area of interest around what's referred to as microstructural MRI, and the Bodiwala reference that was provided in the pre-reading refers to this to some degree. And this is actually something that could potentially be rolled out in most clinics in Ontario if there was interest.
Excellent, thanks. Next one, Jerry. And then this question was sort of more around other therapies and physio and preventative physio rehabs and that. And there were some specific questions around some specific modalities like prolotherapy and PRP and transcranial magnetic brain stimulation. And I think Eldon really covered this very succinctly and very well in his presentation on rehab. And the fact that certainly there is a role for conservative treatment in maybe different stages, both in mild DCM may have a role and post-operatively. The issue would be is not much is really known. There's probably more questions than answers about exactly what these protocols look like. So again, in our small breakout groups, especially when we look at the rehab one, these might be pertinent questions to look at there. And I guess the last one is about clinical outcomes, and I might defer that one again to you there, Michael.
So there is a national registry through the Canadian Spine Society to collect data on a variety of spinal conditions, including DCM. So most surgical centers in Ontario are involved with the with the registry. So that there is that occurs. I think there is an opportunity to do a better job of perhaps collecting data also through ICES. So there might be an opportunity that we might think about around there to perhaps have more granular data. And then the whole issue of pain, I think, is an important area of discussion, and perhaps that might be an area that might emerge in terms of kind of where we might want to go with further assessments and management. I think one of the things that I have seen, and just gets to the raising of awareness, sometimes patients will present to the family physician and they're very focused on neck pain, and the neck pain is important, but I think one of the points that needs to occur, I think potentially from an awareness perspective for family physicians, is to also think about the possibility that there's DCM, and not simply to focus the exclusive interaction just on the neck pain as well. And so that's important. I certainly have seen patients where the diagnosis was made in a more delayed fashion because there was a lot of initial focus on the neck pain.
Yeah, great point. And certainly the pain can be brought up in those small group breakout sessions that we mentioned. So those were mainly the questions that were categorized from last day. I'll just quickly open it up if there's any other questions that people have right now. Otherwise, we'll move on. Okay. If there are questions, again, the chat function is there, and there will be plenty of discussion in the small group and larger group sessions. So that is it from my end for right now. I will just introduce Tara Jeji from the Ontario Neurotrauma Foundation for a quick hello from her.
Welcome everybody. I'm so glad so many of you can join us. Some of you could not join us on the first day. We have 25 people right now, and maybe a few more will join. So I really thank everybody who has taken this time. I welcome you on behalf of Ontario Neurotrauma Foundation. My name is Tara Jeji, and I lead the spine research program for Ontario Neurotrauma Foundation. My special thanks to my co-chairs here, Dr. James Milligan and Dr. Michael Failings. They have given so much time, thought, and their leadership to steer this work forward. This work has been done in 10 to 12 weeks time from its conception to where we are. My thanks to the two planning committee members from both teams, from Dr. Michael Failings' team, as well as team from James Milligan's. Lindsay, special thanks to you for keeping us on task. Our facilitator, Jerry Mings. Jerry, hats off to you to guide us in this work. So with you that, hope for the best for the day. Thank you so much.
Good morning, everyone. My name is Jerry Mings, and I'll be facilitating the session today, and I have the help of some great 6 facilitators who are going to be leading in the small groups. Couple of things I want to do is, first of all, we're going to be focusing on 4 topics, and I'll let Dr. Failings walk you through those topics very briefly. And then we'll be breaking into some small groups, and I'll come back and explain that in more detail. We're on kind of a tight agenda, but it's a good agenda. So the bulk of the time after we finish this part will be you having a chance to talk with your colleagues around 4 identified topics. So why don't we find out about those topics now? Then I'll get you into your groups and I can get you started. And so on that note, Dr. Failings, the topics.
Great. Okay. Thank you, Jerry. So we have had the intros last week, but hi everybody. I'm Michael Failings, neurosurgeon at University of Toronto, and Jamie and I are very grateful to all of you to taking a bit of time out of your schedules to discuss the opportunity to move forward with a strategic and a research agenda around degenerative cervical myelopathy. We're very grateful to Ontario Neurotrauma Foundation, Tara Jeji, and others for helping to facilitate the logistics. And Jamie's also done a shout out to both of our teams. So in particular, Lindsay on Jamie's side has been great. And I wanted to thank Nadia and Tim and Anushka on my side. And of course, our wonderful facilitator, Jerry Minks. And Jerry and I have known each other for a number of years. First time we're doing this by Zoom though. It's a new one. So we are kind of building our strategic directions off a process that had already occurred called the RECODE process. And this was a very good process that was facilitated by colleagues of ours at the University of Cambridge in association with AO Spine. A number of us, including Jamie and myself, were part of this. And out of this emerged 10 top research priorities, which are listed on the left. And we thought that we would try to select the top 3 or 4 priorities for us to begin the discussion. So we did this through the polling. And so the 4 topics that were chosen through the polling are listed on the right. And these will inform our 4 discussion groups. So the first is the importance to raise awareness of DCM among the public, among general physicians, even specialist physicians, including neurologists and physiatrists, and among funders and so on. You know, people just don't seem to have as great an awareness of this as they need to. The diagnostic criteria, and we had a bit of a discussion around this. What are the clinical criteria? What outcome measures? What refinements in imaging need to occur? And then how do we assess patients? You know, what should be the protocol that, say, a family physician would do in their office? How do we monitor patients if we select a non-operative route? And then what about rehabilitation? So rehabilitation is used very frequently. We have a general sense that it's important, but we actually lack granular data on what the optimal rehabilitation strategies would be. And so, you know, that's potentially a knowledge gap that we might wish to address. So you're free to choose a breakout room. Jerry will kind of do the coordination. And Jamie and I will kind of duck into the rooms as observers and to kind of listen in. Jamie will be in the raising awareness rooms and diagnostic criteria room, then I'll be in the other 2 rooms, assessment and monitoring and rehabilitation. So Jerry, back over to you.
Thank you. So this is a good time just to pause for a moment and take a look at this list and identify the topic that you would really be interested in sitting down and talking with your colleagues about. We're going to ask you to do 3 things in the breakout session. 1, with your identified topic, see if you can identify what we could accomplish in this topic. In that brainstorming session, the time window is wide open. It may be a long-term thing you're thinking about. It may be a short-term thing you're thinking about, but you'll have a chance to collect all those different ideas. The second thing we'll ask you to do is to focus and see if you can look at what could we get done in the next year. So that's the second part we're looking at. We'll come back as a larger group and hear from your group to say, hey, we had a conversation. This is the big thing we think we can get done in the next year. You'll go back into the breakout rooms and you'll have a chance to work on your plan for that. Each breakout room has a facilitator. And once you get in that facilitation session, there'll be a chance to type notes. Now, I'm going to put up here a link to the Word file for the notes for your workout, for your group. This has those long, terrible URLs, so bear with me here. Do you see that in the chat? So you're welcome to pick the one group you're going to go to, and they're all labeled, and that will open up so when you're in your small group, you can work with your facilitator. You do not have to be typing away in there. Talk to your facilitator first. I've just tried to make this accessible for everybody. If you're having trouble opening it, don't panic. Somebody in your group will be able to open it. Okay. Now, the next step is I'm going to ask Rushi to open up the breakout rooms, but don't go anywhere yet. I want you to see something. Something should appear at the bottom of your screen that looks like join breakout. Do you see that at the bottom of your screen? Little button that looks like that. When you click on that button, you will see the 4 breakout rooms. Do you see if you click on it, you see the 4 breakout rooms? A list should pop up that says raising awareness, diagnostic criteria. And then on the very right-hand side, you should see this thing that says join. Don't do that yet. Don't do that yet. When you get into the breakout room, your small group facilitator will get introduced to you. You'll introduce each other. Then you can dig into the work. We'll watch the time for you, share your ideas, brainstorm. There's ways to capture it. But remember, our first step in this phase is as many different ideas that guide us into the future with DCM, and then a conversation to get it narrowed down to what do we need to focus on in year 1. Does that help everybody? Lindsay?
So we should probably mention if people do not see the breakout room button and if they are having difficulties.
Stay here. We'll help you get to the right room. Okay. And if you have any problems today and you can't get anywhere, come back. You know, Rushi and I will be here to help guide anybody. So I'm going to take the analogy of a cooking show. This is the first course. This is the plenary fee. Your time starts now. Go join a room and you're welcome to get started. You got to meet people. You can nod at this point. You don't have to type any keys. Did you get to meet some people, talk to some people, push around some ideas? Good, good. Now, this part is a short part because I just wanted everybody to have an opportunity to hear from the different groups. There's only 2 things we're asking whoever's going to present from your group. This is relatively quick. Can you see the screen where it says Guide for Large Group Feedback? Mm-hmm. So you're basically going to say, for example, if your topic was increasing awareness, you're saying, our proposal is that we could get X done at the end of 1 year. Does that make sense? We're in the final report, we're going to have all the other ideas that you collected. But for this moment in time, we're just saying, what is it in year 1 you're proposing that could get done? Just so everybody gets a sense of that. So why don't we work down through the topics. Who's reporting back from raising awareness?
Me.
Me?
Me, Nadia Jaber.
Okay. Topic, and what did they come up with?
Well, we were in the last second. Prioritizing, first of all, the target audience is important, professional health professionals and the public and the patients. That was put as the first priority or first result. And then the second one was integrated and integrated efforts mobilized by the public and the patient, the professionals, in order to do this raising awareness. And the third one, I don't know, because I got kicked out of the room.
Okay.
But there was a talk about what are the resources, online resources available out there for the patients and for the professionals, and also pain, neck versus DCM. This is one of the things that maybe people need to be educated about.
Okay.
I don't have access to the, I should, oh, okay, I have it. Yeah, I have it here, sorry.
Okay.
Yeah, and then the low prevalence of DCM imposes the need for promoting it. So I guess if the group agreed, probably this would be the third result, which we can pressurize. I think the first one will be the determine the target group.
Okay. Who was working on diagnostic criteria? Somebody from that group ready to share an answer?
On diagnostic criteria. In the short term, we expect that it would be a reasonable achievement to provide education and awareness. And we were thinking, I'll give you the how in a minute, but we were thinking that a core place to start where things are being missed are at a family physician level, a GP. And we recognize that subject to their limitations, there would have to be some kind of clinical diagnostic criteria available to identify potentially a constellation of symptoms. And two ways we could do this is by utilizing a MPH student, particular students, making use of undergraduate students and start there, and also educating some of the undergraduate students that are coming through the system as well with regard to some of these diagnoses and problems that people that are currently graduating are not fluent on.
Okay. Who had the assessment and monitoring?
So I was one of the team players there, and we are a little biased because we had specialists only. So we had myself as neurologist and 3 spine surgeons on the team. So apologies for the bias. But in matter of fact, what we discussed is the continuum from the assessment and monitoring from the general practitioner point of view to the specialist. So the first aspect was to raise the concern that there is probably not much available to provide a screening tool for general practitioners, and that which would raise the main points in the history and physical examination that should be checked for a suspicious case of DCM. So that will bring the number one outcome in the short term 1 year from this meeting, which will be trying to do a review of what is in the literature in terms of signs and symptoms of these individuals, to bring it up to a screening to at least a checklist where they can use for their own practicing. The second portion was to consider the algorithm from being diagnosed in the beginning, but then what to do with these individuals. And then our own expectation would be to send to a specialist, and we may be wrong, maybe the general practitioners would have a different impression that they could see these patients in the long term, monitoring them. Regardless, we need to have better outcome measures for that matter. So we need to have a better sense of what is currently available in the literature and see the gap, the knowledges, sorry, the knowledge gaps that we have in terms of the outcome measures. So that brings the number 2 and the last point in terms of 1 year achievement that we are proposing, which would be a comparative study in terms of a literature review of the outcome measures in DCM, recognizing that this group is heterogeneous and likely there are, as we see in the clinical practice, phenotypes of the disease. So probably one outcome measure may not be
Okay, thank you. Who had the last group, which was rehabilitation?
We didn't decide on a speaker, so I can just give a bit of a summary. So we were still kind of in the brainstorming phases and kind of had come to the conclusion that the severe cases of DCM really are really the more straightforward. It's easy for the surgeons to recognize that they can't go home and have to go to rehab, and they go to inpatient rehabilitation. We use traumatic spinal cord injury principles to guide their rehabilitation. So the focus of our discussion was really more on the mild to moderate that oftentimes either don't have surgery or post-operatively can go home, and it's challenging to get resources and approach for rehab in the community, especially as there's such a heterogeneous population. So some of the key things that we had come up with were getting some clarity around demographics and how many of these patients are there out in the community, so that we can start putting together some guidelines for how do we get access to resources in such a resource scarce healthcare situation that we're in right now.
So thank you, everyone. Now you're going to get a chance to go back into your group. One of the things to think about is that this first thing, your proposed result for year one. When you think about a proposed result, one way to sharpen that is if this was a year later, what would you be reporting as done? That's one way to think about it. That's what would be done at the end of that year. You can sort of sharpen up your statement and look at that. And number two, then you can get into the how to get to the end of next year. And that may help you sort of with the steps that you've started to identify. The key is, if this was a year from now, what would you celebrate as done is the first step in a longer journey. So take that in mind as you're moving forward. We're going to send you back to the small groups again. Just waiting for the little icon to come up. There it is. And if you have problems going to your group, not a problem, we'll get you there. You're going to have, I believe it's 20 minutes. Am I correct, Rushi? Roughly, she's checking my math. You got about 20 minutes and away you go. And good luck. You're on the right track. It's going to tell you what's going to happen next. We're going to give each of the groups 4 to 5 minutes to do a short presentation. You've already talked about your topic. You've talked about your proposed result, but you may have sharpened that a little bit in this conversation. The outcome, which was an important question. So if you do this work, what's the outcome? You don't have to read through every one of the steps you're going to go through, but you may want to highlight 1 or 2 because you think it's important for the group to know. So that's basically what we're going to do for the feedback. We'll have 4 sessions. The question was asked, can I share my screen when we're doing the presentation? The answer is yes. And I'll turn my screen share off in a minute. Is that clear for everybody, the steps? About 20 minutes. We'll go through that. If we have a time, we'll take maybe 1 or 2 questions, but we'll keep moving through this. And I want to reiterate again, all the good ideas you put into those worksheets, they'll all come back to the Summit Steering Committee, so nothing will be lost. This is just a highlight to get a snapshot. So I'm going to stop my screen share. Let's do this in reverse order this time. Let's go to rehabilitation. Who's going to speak?
Okay. I guess I can speak again.
Yeah, you can.
So the steps would have still been helpful to have up there.
You want the steps back up on the screen?
Yeah, if you don't mind.
Not a problem.
So again, so our big thing, that the big gap was in the mild to moderate DCM, for which there is very little evidence for the rehabilitation and even for the demographics, because these people are oftentimes, like, no one really has this information. They don't make it to specialists. They don't make it to rehab. So our proposed result was eventually to get to, based on mainly expert opinion, but a consensus document on guidelines for rehabilitation of mild to moderate DCM. And really focusing on using expert opinion and the resources of people with lived experience and what has been helpful for them. It's quite a large undertaking for 1 year, so we kind of thought maybe we'll subdivide into a domain to focus on for the year, especially considering that pretty much all of those involved in spinal cord injury rehabilitation in the province are part of a quality improvement consortium for traumatic spinal cord injury that is currently undergoing. So there already is a lot of work being done to improve care for spinal cord injury patients, so the resources are quite thin. But it's very much in agreement amongst our group that it would be very helpful to at least have a starting point with, even with the paucity of literature, to have expert opinion and person with lived experience based guidelines as a stepping stone. So major steps would be essentially figuring out who is going to spearhead this, getting the group of expert opinion together, putting together some sort of survey to get opinions, and then get an expert panel together to sort of refine them. And amongst all of the different domains that we would need to cover, including things like bowel, bladder, upper extremity, mobility, mental health, sexuality, pain. List is quite long. Yeah, so basically our year 1 is rolling into years 2 through 5 of trying to get those, get an expert opinion consensus document together.
Yay. Thank you. Thank you, thank you, thank you. Okay, let's move on to the next group, which was, going from my list from bottom to top, assessment and monitoring. Do you need the screen?
You can leave the screen, please. I'm not using my screen. Oh, you can jump to the other screen. That's fine.
Yeah, if you want it.
No, that's okay. That's okay. I remember the screen. That's okay. So what we discussed was initially to do to develop a screening tool for general practitioners, and if I actually brought it, there are a few screening tools. One is Down's questionnaire, but what we're discussing is something that's more comprehensive. It's for any clinical practitioner to consider as a reminder what to look at in terms of symptoms and signs of a patient with DCM in different degrees of the manifestation of the disease. So that would bring it to the next step, which would be then that you recognize that there is a patient with clinical suspicious, what to do, what you would bring to the idea of developing an algorithm of this assessment to monitoring these individuals. That for that matter, we are now in the year 2 to 5, where would bring probably a panel of experts to discuss the algorithm and developing this for general practitioners, but also including now the group of specialists that would be involved in the care of these patients, which you would bring in the number 2 portion of it, the outcomes of this meeting, which would be what are the actual outcome measures that we can use to evaluate these individuals longitudinally that can give you a sense when they are worsening, and then when they are worsening, jump into the algorithm and say, what is the next step? When to refer these patients to a specialist such as a spine surgeon for a surgical treatment. So the whole idea is from the beginning to identifying these individuals when they come in the first time with any complaints, to raise their awareness of potential differential diagnosis of DCM, to the end point when they receive the treatment that could be either surgical treatment or follow up with a specialist, and then monitoring, and also links with rehabilitation eventually.
Thank you. Let's go to the next group, which was diagnostic criteria. Who had that one?
That's going to be me. And I was told there was going to be screen sharing available. So
And I'm going to do that. Yeah, you can share your screen. Yep.
All right. So we had diagnostic criteria in our year one result. We came up with two things that we thought we would like to do, because why can't we work on two things at the same time, which would be very nice. First, we thought doing a scoping review of the diagnostic tools and identifying the holes in the data for that. So either getting a master's student or an undergraduate medical student to do a review of the literature, get GPs and neurosurgeons as well to offer their insights with that. And because in particular, certain mild, moderate cases certainly aren't going to make it to the neurosurgeon. So to make sure that everyone has that input in there. We also thought of including other ancillary practitioners that are primary contacts, such as physiotherapists and chiropractors, who also should be doing active screening for this sort of condition, because it is something that they will see. And often when patients are not going to their primary care provider first, they're going to go to their physio or their chiro. That's something that they need to be aware of. The second thing that we thought would be good as well is identifying the lack of imaging infrastructure in Ontario. Many of us are around the GTA, and that access can really be physically and temporally quite good. But you head an hour or two north, and all of a sudden things become very challenging. So looking to see what can be done about the infrastructure for medical and diagnostic imaging. Back to the scoping review. In year one, we're hoping that we could have identified gaps in the understanding of the diagnostic tools and the clinical signs, and identifying that we can have a list of DCM red flags that would warrant further assessment, and particularly for things where it's not going to be textbook. You have to put that clinical picture together, and you have to be suspicious, but the best way that we can be suspicious is when we know what we're looking for and we're ready to find those things. And so putting all of that together. And then in years 2 to 5, looking at how can we fill the gaps that we have found. We've identified them. What's going to be a useful way going forward so that we can make this clinically relevant for both practitioners and patients. And looking also at a cost benefit analysis is helpful in justifying that research. It's great when we can all say, hey, clinically this is good, but we know that money has to come from somewhere, and one of the ways that the government understands that is in a cost benefit analysis, so that we can prove not only is this clinically relevant for us and patients will be happier and will vote for you, but it's going to help fiscally as well, which is just a reality of having to run healthcare. And then going back to with imaging, just making sure in year 2 to 5 that are we able to build in the infrastructure to remove those barriers. I didn't bring this up in our group, but it's something that I always wonder. We've had so many advances in technology in the last 20 years. Why does this not come with an MRI app? Why can't we just have an MRI this size? We can do it upright, we can do it lying down, we can do a 3D panoramic view. It should be there. So perhaps we'll have to push that to 5 years, might not get that done in 2, but that's what we have come up with.
Thank you. Let's do the last one, then we'll have a brief conversation. Who was working on raising awareness?
I was part of the group. And Nadia, can you share what we had written down?
You should be able to share screen, yes. Ah, there you go.
Here we are. Okay, so yeah, so it was really to look at raising awareness through joint efforts of health professionals and the public. A lot of the discussion was with regards to more focus on health professionals, and through traditional places like conferences, small meetings, and with online resources. In Ontario, or for primary care, there are things like the Ontario Annual Scientific Assembly. I mentioned also, not written down, but the National Family Medicine Forum as well. There are international conferences like ISCOS and other such conferences. There was a discussion about it actually being, some of them might be sponsored presentations as well, to just raise awareness to a higher level, to promote awareness and attendance. That myelopathy.org is there as a way of trying to align the raising awareness with resources that are already in existence, as well as raising awareness with trying to bundle it with other conditions that might present in similar fashions. For example, other conditions that might present with neck pain or with paresthesias or other such things. And so tangible outcomes would be to have presentations conducted in various areas in the community: primary care, spine surgery, orthopedic surgery, and to, as I say, develop these with the other conditions there, and having promotion of these resources through the public and clinicians.
Thank you. Did we cover all the groups? I think so. Okay, so 2 questions I'm going to ask just before I hand it over to the co-host to take you through the last steps. Was there anything that you heard that you weren't clear about? Because this is a great time to ask for any questions of clarity. You may have heard something in the presentation you're not clear about. Any questions of clarity? Then let me ask this next question. Did you see any patterns? Did you see any sort of things that this group talked about this and it's kind of similar to another group talked about this, where you saw something that's starting to come together, like it cut across the different topics? Anybody?
Yeah, I certainly saw awareness was an issue, raising awareness.
Okay, awareness. Any other topics that you saw cutting across before?
I think one of the things we noted was the importance of the GP and also other primary access points for people who may go around their GP in terms of accessing care for pain management, and including that whole team in every step of the way, because not everybody gets to surgery. Only a small percentage of people will see a surgeon. And also the focus on, mild to moderate. What can we do to prevent us from getting to severe, right? That's maybe something I haven't seen, but that I'm wondering about. What can we do to prevent us from getting to severe? Do we need to get them earlier? Is that part of our lit review? I don't know.
Any other observations where you saw some patterns in this?
Also that the constellation of symptoms are multifactorial, very difficult to identify What would we do if we did not have imaging? How difficult would this be to identify the mild to moderate, as Melanie suggests, and that some of these practitioners outside of the medical community, such as the physiotherapists and the rehabilitative practitioners across the board, chiropractors, may be seeing a number of these patients and not identifying them, which also could be a potential hazard to be avoided.
Any others?
I think another common theme has been diagnosis at different settings and management. How can we diagnose them at rehab, in primary care, or at surgical outlook, and how we can manage. So around the continuum of care, how can we diagnose and manage them best in different settings? Is a cross-cutting in these things.
Any insights about the next steps that people propose? Did I cut somebody off? Were you going to say something, Jamie?
Sorry, Jerry. It's Jamie. I might just add in some really interesting discussions in the two groups that I eavesdropped on about, equity in care, right? And the lack thereof, really needing to be very conscious of the different resources in different places and the different types of populations. And, kind of comes back to what was said there. We used to talk about in medicine and other things that, the major point of how we diagnose things was through a history and physical exam, certainly going a long ways back where we didn't have advanced imaging. Now, I'm not saying we step back and we don't have advanced imaging, but I think a very good point is raised there when we try to bring some equal footing to how we diagnose and manage this, if maybe some of those barriers are going to exist for a little while.
Anything else? Just put those little list of ideas in the chat here with some funny typing. So just before I turn it over to the co-host to talk about next steps, did you have any insights about next steps based on today?
Are you asking Jamie and me to comment, or?
I'll let the group comment first, and then you can follow up just to hear from the group. Just some thoughts on next steps.
I guess one comment that came up in our discussion, I think it came up in the summaries as well, is just, what are the resources that are going to be available for us to take these next steps? And I guess, what are the expectations of people who are going to be participating? Because we're all being pulled in various directions. So having kind of that capacity to do that, both from, a financial and also a person perspective, given the other that kind of initiatives that are ongoing, especially within rehab, which is how it came up in our group.
And then I'll cover that in my ending remarks.
Okay. Just asking, any other general things about next steps that came up for people? Then I'll go ahead.
I have a question for the group. And do people feel that there might be a need to have a future meeting to perhaps to discuss this topic? So would there be value? That would be, I think, one of my questions as well would be, we've tried to do, 2-hour meetings in the COVID era with Zoom. you know, is this a topic that would warrant some future discussion to bring everybody together? I don't know whether we could just see a show of hands, or could we put up a poll question? Would that be worth? Are we able to do that?
Put up a poll question.
On whether we should have a future meeting.
Well, we can do another thing. If you go to the participants list,
yep.
If everybody goes to the participants list, down at the bottom of the participants list, you should see something where you can raise your hand. So in answer to that question, just try that right now. Raise your hand. That'll give you a good indicator.
Since I can't find the raise my hand, I'll vote for Dr. Felling's suggestion that we just raise our hand.
There you go.
I can't find the raise my hand, so I'm in.
It's under the participants list, but that's okay. If you raise your hands, that's good too.
So
the overall response is favorable.
okay, I'm glad to hear that, because I think that you know we're going to have our work cut out for us now. I think to try to collate all of the information that's been received in terms of the identification of the 4 areas of priority, and then a lot of the excellent discussion that's gone on in terms of the ideas around what might be the next steps and how to implement this. And we thought we would kind of put this together in terms of you know, kind of a white paper document, but kind of a more of a, I think, a working document that then might, you know, inform future processes. But one of the points that continues to resonate is the importance of raising the awareness at all levels. So in society, with people, funders, as well as healthcare professionals. So I think this is, you know, a very clear priority. Jamie, I don't know if you want to comment from your perspective.
Yeah, I mean, yeah, I agree, Michael. Clearly, for one, I'm glad to see that what we're doing here has, you know, a lot of backing and interest. I mean, that's really important. So that's going to be great in terms of moving forward. As you said, we'll have a big job in terms of putting this information, and then we'll disseminate it to everybody in the form of a summary type of thing, and where we go from there. Yeah, I mean, having been involved in the recode stuff with Michael, the awareness consistently came up in that as well. So I guess it's not too surprising to see that here. It's nice to see that it aligns with that. And I think then we have to make sure that we align with other agencies like Recode and other thing like that, to make sure that we're not duplicating things and trying to learn from others rather than maybe trying to do the same thing, which is a common problem. So so that is good. And I just think there was definitely some really unique Ontario-centric types of views that came out of things that is really the other portion of why we wanted to get such a wide group of people together, and not just sort of take the Recode things for the face value and the great work that they are and just instantaneously apply it to our setting. I think there's a lot of nuances and a lot of really important things that came out of this. So yeah, no, I was super pleased with how the process went. And definitely we're going to try to keep this moving forward and have some type of a strategy.
I guess
go ahead, Michael.
One of my questions would be just to kind of to explore whether we might be able to put together some working groups to further develop some of this. You know, we'll collate the information and but I think to kind of to implement this, we may need to kind of to do some post meeting work as well around some you know, kind of some focused meeting groups. So you know, there might be some ideas that you know, that could emerge.
So you're asking if people would be interested in that, or just
I'm
the
kind of
thought of
raising it as I guess I'm kind of raising it as a you know, kind of as a suggestion. So, you know, if we kind of look at, for example, the raising awareness perspective, okay, so great, we're going to have the suggestions and they're going to emerge, but they're going to need to be people or groups that will wish to potentially to kind of to work to, you know, to try to move this potentially to try to move this forward. So I'm just kind of raising that as that maybe that would also be kind of one of the next steps we might want to do, would be to survey this group and maybe even to extend it further to see if there might be you know, an appetite to move you know, to move this forward with regard to, you know, working groups.
I'm going to go to Tara.
That is a good suggestion.
So I heard loud and wide what Michael, just to start from where you ended, is how to keep, I think this is a great group we have. Maybe this is the inaugural group for DCM in Ontario. So we should keep this group, and then maybe there will be snowballing from here. We will have more attraction. People will get to know who's there. So as you said, let's do something follow up. So what we have heard today, we will put those things together. We will come up with some recommendations, look at the priorities, and then we will see what resources we can do. Yes, for surely we need the resources, but we need people like you to lead and people like you to form working groups and say, this is what I can do, and these are the resources what we need. And my job will be to provide those resources, connect you to those places, connect those points, but we will come back. So, but what we would do is, if everybody will be agreeable, Michael, maybe in a few weeks, we will set up some dates and see what we heard. Is this right, what we are putting together, what we heard from you? You go back and think, can we add something to this, something we missed from this? You heard something, you share this with your own colleagues, and we meet together and see these are the priorities. We want to develop something like a white paper, which will be a guiding document for us to move forward, and we will see what we can do in year one from that, year two. But we want you to be engaged in this. The success of today's meeting will be our being together and naming this something. And I really, really thank for the leadership providing Dr. Failings from you, Jamie from you, and all the work you have done over this time frame and the time you have given. I really thank each and everyone who is involved. If you have any questions, you can send it to me. I'll be happy to respond, but we will be sharing our discussions in few weeks and see what we have heard, what we can do. Are our priorities aligning with what you think, what the system is going to do? Again, we have to see we have seen that what is in Toronto, we don't want anything to be very in big cities, how we can look at this problem in smaller communities, how we can develop some diagnostic tools which can be used by specialists, primary care physicians, allied health services in remote areas as well. And that is very near and dear to my heart as well. So we will keep you engaged, and thank you very much for being so interactive, doing all the work and putting this together. Thanks to everybody, teams from planning committee. I do want to thank each and every one of you. Thanks, Jerry, for leading us, facilitating us, and telling us and following this process. Jerry, you have been very instrumental in telling what to do, how to do, and we are thankful for that. And thank you, everybody, and we will follow up with you.
I have one more task after that. It's the group photo. And the group photo requires one thing. You need to turn your camera on. Okay. Now, you need to get loosened up and kind of figure out how you want to be seen in the picture. I will do my best job to get a good picture of us. Yes, you sort of lean in there and kind of look, you know, like in control. Are you set? I'm about to hit the shutter button here in a second. A big smile on your face. And here we go. Well, just bear with me here. I'm going to get this one here so we get a proof of it. It's not bad. Let's take a look. Share my screen. Can you see it there?
No.
Well, it helps if I share my screen. There. Can you see it there?
Wow.
Jerry, are you going to add people
Great.
missing?
Well, yes, we can add people who are missing, but there's some people who didn't have, well, some people turned their camera off. But anyways, that's what we've got so far. And then we'll add the names of the people who weren't here. So there's a screenshot for us. And on that note, closing remarks, and then you'll be out of here on time. So I'll leave it to the co-chairs, closing remarks.
I want to thank everybody for their great work in attending, and big thanks to you, Jamie, for your collaboration on this, and big thanks to Tara and ONF and to our teams led by Lindsay and the group, and also kind of my team, Nadia, Anushka, Tim. And I think it's a, you know, it's a great opportunity. This is a very common condition. It's one that is hugely under-recognized. There are effective diagnostic approaches, treatment approaches, but there's certainly a lot of knowledge gaps and opportunities for next steps. So really thank everybody's engagement. I love the pictures, Jer. Great. Nice.
Pictures.
Over to you, Jamie.
I'll just close off as well, saying thank you to all the same people. I really echo that. And thanks for everybody to come together at really pretty short notice. We put this together pretty quickly, and we had everybody pretty much accept. So that's great. This is a really unique opportunity because you don't see too many aspects of things where we bridge so many different disciplines, you know, from allied health to primary care to specialists to people with lived experience, you know, and others. I don't want to forget anybody. It's really not that common that happens. So again, thanks, a special thanks to Michael and his group as well. They've been wonderful to work with. So from that, I would just say, again, thanks to everybody, and have great holidays coming up, and we hope to be in touch very soon.
Very good. Okay. Thank you, everybody.
Be well.
Bye-bye. Bye-bye.